This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2015, all rights reserved. My name is Shauna Strickland. I'm a respiratory therapist, asthma educator, and Associate Executive Director of Education at the AARC. I welcome you to today's presentation, Lung Protective Strategies in Neonatal Ventilation.
Jaegere thanks the AARC and Dr. Kessler for facilitating this webinar discussing neonatal ventilation. As a provider of neonatal care devices designed to provide a nurturing environment for babies to thrive, parents to nurture, and caregivers to work efficiently, we are proud to sponsor this webinar. Jaegere understands the key challenges that you face and design our products to help you meet and exceed the challenges of improving outcomes, containing costs, and achieving greater patient satisfaction. Jaegere's comprehensive portfolio of products include thermal regulation devices, transport solutions, jaundice management, delivery room resuscitation, patient monitoring, and of course, neonatal ventilation. Our BabyLog VN500 platform offers a comprehensive array of features including invasive and non-invasive ventilation as well as oxygen therapy. Thank you again for attending today's webinar on neonatal ventilation, and to Dr. Kessler and the AARC for bringing you this presentation. For more information about Jaegere's products and solutions, please visit www.jaegere.com.
Thank you, Reagan. Upon completion of this AARC webcast, participants will be able to understand key unique aspects of newborn respiratory physiology, be able to identify the basic principles involved in neonatal ventilator-induced lung injury, and understand the importance of optimizing lung volume and tidal volume. Be familiar with basic differences between volume-controlled and pressure-controlled volume-targeted modes of mechanical ventilation. Understand the rationale and know the available evidence in support of volume-targeted ventilation. I am pleased to welcome Dr. Martin Kessler. Dr. Kessler is a professor of pediatrics at Brown University and Director of Respiratory Services and Associate Director of Neonatal Intensive Care at Women and Children's Hospital in Providence, Rhode Island. Dr. Kessler's research focuses on advanced modes of conventional and high-frequency ventilation, prevention of lung injury, and treatment of pulmonary hypertension. Dr. Kessler discloses that he is a consultant to Jaegere Medical. He chairs the Data Safety Monitoring Board for a research study sponsored by MetaPost America. He also chairs the Scientific Advisory Board of Discovery Laboratories. I disclose that I am a paid employee of the American Association for Respiratory Care. Dr. Kessler, welcome to the program.
Thank you very much, Anna, for that kind introduction, and welcome to the webinar. I always enjoy talking to respiratory therapists because, unlike the doctors, you actually understand what I'm talking about. So let's begin. You heard the objectives, and hopefully we'll achieve those and leave a little bit of time at the end for some questions. So you all familiar with most of these little acronyms. We have a virtual alphabet soup of acronyms describing lots of different modes of ventilation and devices at our disposal, and the engineers have done a fine job in making gadgets for us to use. Our understanding of when and how to optimally use them, however, is still lagging in some areas. So let's try to sort some of these things out. Now, I know some of you are neonatal specialists in respiratory care, but perhaps many of you are not. So I thought it would be very important to appreciate some of the differences between children and adults. But as I point out, not only children aren't simply small adults, newborns aren't simply small children. So initially, in the first days of life, we deal with the transitional circulation, which means oxygenation isn't just about the lungs. It may also be circulatory issues. Importantly, the chest wall of a premature baby particularly is very compliant while the lungs are stiff. This is why they retract when they breathe. They overall have very unfavorable chest wall mechanics, making them more susceptible to fatigue and respiratory failure. The more premature they are, the more limited their muscle strength and endurance. And very important is the immature respiratory control that they have. And it affects, in a very important way, the interactions between the baby and the ventilator. They're little, so they breathe fast, and they have short time constants. And the ventilators need to adapt to that. Because of their small size, they have narrow trachea, narrow endotracheal tubes, and therefore high airway resistance. And that's particularly important when we ask them to breathe spontaneously through those narrow tubes. We use uncuffed endotracheal tubes, which means there's almost always a leak, which importantly affects how we can measure tidal volume. And that's an important aspect we'll talk about in some detail later on. And to make things more exciting for ourselves, we allow our babies to be awake and breathe, as opposed to the heavy sedation more commonly employed in adult and pediatric ICUs. So it's important to understand the pathophysiology, and equally important to hopefully have a device that's actually engineered with some of these issues in mind. Well, here is a little schematic of what we're trying to prevent, and I'm not going to go through detail. This is from a review article, but it points out how this lovely, nice, healthy alveolus can very rapidly become injured, and there's a complex cascade of events, starting with biophysical injury, which then leads to release of various vasoactive mediators and a cascade of events, activation of neutrophils, and very rapidly this lovely healthy alveolus can become very unhealthy, filled with fluid, and filled with debris. So we will address some of the ways in which hopefully we can prevent this. I will not spend a whole lot of time on the chronic lung disease of prematurity known as bronchopulmonary dysplasia. The point of this slide is to indicate how multifactorial it is. There are all these events that affect it in a negative way, and there's a few that are perhaps salutary. But lung injury can begin already in utero during fetal lung development with exposure to inflammation. But perhaps the most important event is around the time of delivery with initiation of air breathing. And this is where we are most likely to cause lung injury very rapidly. So we'll try to avoid doing that, and we'll talk about how we can best accomplish that. So here we have our little baby, and who is premature, who is having some challenges in establishing an adequate functional residual capacity immediately after birth. So as you know, the fetus lives in a fluid-filled environment. The lungs are filled with fluid, and baby must, in a very short period of time, clear that lung fluid, draw sufficient volume of air into his lungs, and retain that functional residual capacity at the end of exhalation. That is something full-term infants usually accomplish fairly well, but in a very premature baby with all of the listed limitations, this is much more difficult. And so we often must provide a little bit of help. So the most basic thing that we can and should do always in stabilizing a premature infant is to use end-expiratory pressure. So this slide shows what happens when you ventilate, in this case premature rabbit, with 0 PEEP on the left hand side of the panel. And here you can see there's really virtually no air. So in this slide, this is a phase contrast radiography, so air is white. So these lungs are not aerated at all. at the end of exhalation, and even in peak inflation, there's very little air to be seen. With 5 centimeters of PEEP in the right-hand panel, you can see that there is some residual air at end expiration. I hope this projects well enough, and there is certainly much nicer aeration with inflation. And this is these radiographs were taken after 20 inflations. So in a fairly short period of time, adequate FRC can be established when you use adequate PEEP. Not so much when you fail to use end expiratory pressure. So end expiratory pressure is very important in helping get the lung open, and I'll explain why it's so important that the lung be adequately opened up. This slide points out the benefits of various measures to help establish FRC. On the right, 2 columns indicate I'm sorry, something's popping up on the screen, indicate that with no PEEP, whether you use a sustained inflation or not, there is not very good aeration of the lungs. On the vertical axis is functional residual capacity, the volume of the lungs at end expiration. You can see on the left hand the 2 columns showing that when PEEP is applied but no sustained inflation, many of the animals were able to achieve good aeration of the lungs, but some were not, as indicated by the lower section of that column. Whereas sustained inflation did seem to uniformly, with one exception, achieve very nice functional residual capacity. So there's been a lot of interest in sustained inflation in the delivery room as a means of facilitating transition to extra-urine life, and there are several clinical trials that suggest that it may be of benefit, but we're not quite there yet. This study by Ariane Tapas, published a few years back, showed that in the comparison that they made, which included some differences beyond just whether or not sustained inflation was given. But clearly, the group that received sustained inflation followed by PEEP had a significantly lower rate of intubation in the delivery room, required shorter duration of respiratory support, less frequently needed more than 1 dose of surfactant. Survival was excellent in both groups, and there was lower incidence of chronic lung disease, marginally significant, no difference in intraventricular hemorrhage. So that was encouraging, but as I said, there were some limitations to that study. There is another study that was published 5 years ago now from Italy, and this was a cohort observational study. Their control group was a historical control. This is what used to happen. They changed something, started using sustained inflation, but probably changed other things as well. In this study, it appears that sustained inflation has a tremendously positive effect with extremely low p-values signifying a very significant benefit of sustained inflation in terms of things like need for mechanical ventilation, the ability to use only in and out surfactant as opposed to more surfactant being given with intubation, shorter duration of respiratory support, the ability to provide non-invasive support exclusively, and various other advantages. There was no difference in pneumothorax, there was no difference in other complications, and there was a substantially lower incidence of chronic lung disease. Well, that would be wonderful news, but this study has obvious limitations, being a historical comparison. More recently, the same investigators, or at least Gianluca Lista being the lead investigator from Milan, published a randomized controlled multicenter trial, and therefore obviously a much more valid evaluation of the intervention in a moderately sized study, nearly 300 infants that were quite premature. The inclusion criteria were up to about 29 weeks gestation, averaging about 27 weeks, about 900 grams. The groups were fairly well balanced. The intervention consisted of a sustained inflation at 25 centimeters for 15 seconds, which could be repeated once, followed by PEEP of 5 centimeters compared to just PEEP from the beginning. So PEEP is now standard of care. So that's a comparison group. And all they could demonstrate was that there was less need for mechanical ventilation during the first 72 hours of life in the intervention arm. That was their primary outcome, and they met that primary outcome, but they could not demonstrate any of the other benefits like reduction in chronic lung disease that they saw in their not well-controlled earlier study. So this may be a variety of reasons for this, including new centers that may not have performed the intervention equally effectively. It could be other findings, but the benefit clearly is not as dramatic as we originally thought. And there was a bit of concern because the incidence of pneumothorax was 6% in the intervention group and 2% in the control group. This doesn't quite reach statistical significance, but it's a little bit concerning. And obviously, we always want to make sure we're not causing any harm. So there is currently a multinational clinical trial underway that I'm leading along with Harish Kirpalani and Peter Davis from Australia. It's taking place in the US, in Australia, in several countries in Europe, and a couple of sites in Canada. Which will hopefully ultimately tell us whether this is in fact the right intervention. So stay tuned. We are not recommending that this be done as a matter of routine, but it's a promising way to get these babies started, and the hope is that it will allow these babies to fairly rapidly establish adequate lung volume and subsequently be able to breathe spontaneously. Because one thing that most folks are very much convinced of is that the best way to avoid ventilator-induced lung injury is to avoid mechanical ventilation altogether and provide non-invasive support. We're not going to talk about non-invasive support today, but that is in fact first-line treatment when babies are sufficiently vigorous to do that. What we are going to talk about is, well, what if we do in fact have to ventilate? And specifically, we're going to focus on what is the best way of providing that respiratory support with the least amount of damage. And focus on the question of whether pressure or volume should be the primary control variable. The last time we seriously asked ourselves that question was back in the 1980s, from which these two ventilators originate. Some of you may remember the old Borns LS-104, an old volume ventilator. Not designed for babies, did not work very well in babies. The BP200 was a very simple pressure-limited device, and that is, in fact, what has become pressure-limited ventilation, pressure-controlled ventilation, has become standard of care for many years in the neonatal intensive care unit for a variety of reasons, including the ease with which it could be applied and the conviction that pressure is the primary cause of lung injury. And we'll try to convince you that that's in fact not the case. I will try to convince you, and I'll show you some evidence for that, that it's excessively large tidal volume, not pressure by itself, that result in lung injury. I think you all, anyone who has dealt with newborns knows that it's really easy to inadvertently drive down their CO2. And most of you, I think, know that low CO2 is bad for the brain. It's bad for the lungs as well. But in premature babies, it increases the risk of bleeding in the brain and having an ischemic type of injury, periventricular leukomalacia. So it's something we would like to avoid. And I will show you why it's not so easily done as many people have tried to take the adult type of volume controlled ventilation to the NICU and expect that it works equally well. So, some data that are not very new, but very important to address the issue of pressure versus volume. So here is an old experiment that applied various levels of inspiratory or inflation pressure on the horizontal axis, and on the vertical axis is what's called a capillary filtration coefficient, which is basically a measure of acute lung injury or lung edema. So this was a short-term experiment. And what they did was they had a control group, just regular as is, rabbits, and they have animals in whom there was a plaster cast applied around the chest and upper abdomen to limit tidal volume excursion. And so what happened? Well, at low pressures, nothing much happened. Low pressures don't cause overdistension, so there was not any increase in capillary filtration coefficient. At 30 centimeters of pressure, there was a substantial increase in the coefficient, was statistically significant, but only in the group in whom the lungs could freely expand. There was no increase where the tidal volume was restricted. It's not surprising that when you applied 45 centimeters of pressure to animals with normal lungs, with normal compliance, that there was a dramatic rise in acute lung injury, as indicated by the filtration coefficient. What is very surprising to many, I think, is that when you constrain the chest wall movement so that the delivered tidal volume, in fact, remained in the physiologic range, that despite exposure to those very high pressures, there was no increase in the capillary filtration coefficient. So pressure, without causing a correspondingly large volume, does not in fact injure the lungs. The lungs are in fact injured by overstretching, as illustrated here in this cartoon, when the alveoli are stretched to excess. That is when a lung injury occurs. And so the pressures don't have to be extremely high. If the lung is completely normal with very good compliance, even a moderate pressure can overstretch the lung and cause injury. Something to avoid, something to remember. But in fact, we have over the years developed a serious case of barophobia, thinking that pressure is really the culprit, and it is not. Here's a bit more evidence for that. A similar experiment in some ways. Again, animals who are exposed to different levels of well, to very high pressure in this case, but under different circumstances. They again looked at 3 different kinds of acute lung injury. Essentially, again, lung edema and protein leak. So short-term experiment, acute lung injury. It's similar groups in terms of in red. The red columns show animals that were exposed to high positive pressure of 45 centimeters, resulting in large tidal volume. In light blue are animals who are exposed to high pressure, but limited tidal volume because of a tight elastic bandage around the chest and abdomen. So again, there was a lot less lung injury. And in yellow are animals who had negative extra thoracic pressure generating a large tidal volume. So you remove the pressure factor, you still have very large tidal volume, and you have a lot of lung injury. So volume, not pressure, is what's primarily responsible for lung injury. So it makes a lot of sense to try to control tidal volume directly as opposed to rely on pressure, because, as you know, the tidal volume that's delivered to the lungs is a function of pressure that we apply in the compliance of the lungs. And the compliance of the lungs in a newborn infant soon after birth changes rapidly. And that's where we get into trouble. So here's some more data in just to impress you about the importance of trying to keep tight control on the PCO2. This is a large observational study where they looked at what factors are associated with increased risk of severe interventricular hemorrhage. And disappointingly, just ventilation by itself, in and of itself, in multivariate analysis, was in fact responsible for a significant increase, a doubling of the risk of severe interventricular hemorrhage. Having a very high CO2 in the first few days of life was not good, doubled the risk. Having a low CO2, and it didn't have to be very low. We all knew that even a moderate, I'm sorry, I'm a little behind here, even a moderately low CO2s can be dangerous, but even in this case, it seemed that even modest lowering of the CO2 resulted in a significant increase in the risk. So these are all good arguments for trying to get a grip on delivered tidal volume. So great. Well, we have ventilators that can deliver controlled tidal volume, right? We have volume controlled ventilators. We use them all the time in the adult and pediatric ICUs. Why not just take one of these machines and put it on a baby? Well, we tried that back in the 1980s, as I told you, and the problem is it didn't work as well. Now, these machines have gotten a little bit smarter, and there are some refinements, but the basic problem with volume-controlled ventilation is that what is controlled is the tidal volume that's delivered into the proximal end of the ventilator circuit, where that double V is. I'm not sure my pointer is working. I think it's not for some reason. So back here at the ventilator is where the tidal volume is measured and generated. And in a large patient whose lungs are much larger than the circuit, it's not a big problem. There's a little bit of loss of volume into compression in the circuit, but that's easily compensated. But when the lungs are tiny in a small preterm infant and they're smaller than the volume of the circuit and humidifier, then that loss becomes much more dramatic. And so without going through the math here, you can appreciate that the smaller the baby relative to the circuit, the stiffer the lungs, the more volume is lost to compression. Up to a point you can compensate for this, even though it turns out that even under the best of circumstances, you usually have to set a tidal volume of something like 15 mLs back at the machine to get an actual delivered tidal volume to the baby, about 5 ml per kilo. The problem is that leak around the endotracheal tube, which now becomes a wild card. That leak tends to be highly variable and not easily compensated for. So even the ventilators that have compliance compensation and all of that, that all breaks down when you have a significant leak around the endotracheal tube. So that is the challenge. Now, what can be done, and some of the ventilators allow for that, is you can put a flow sensor at the airway opening, and you can measure the exhale tidal volume, and you can adjust your set tidal volume, your tidal volume delivered into the circuit, to achieve that exhale tidal volume. And in one large study it was done, and they documented that you can in fact use this kind of volume control ventilation when you measure the exhale tidal volume. But it's a bit complicated. You have to do those adjustments manually. So to try to get around these issues, folks have come up with modifications of pressure-controlled ventilation that alter some parameter to try to target a set tidal volume. And in essence, basically, you can either alter the inflation time or the inflation pressure. And I'm not going to go through all the different devices and how they achieve it. Increasingly, the newer devices and some of the older devices are adding this modality. Things seem to be gravitating toward the basic concept of volume guarantee ventilation, which I will explain in a moment. But the basic principle of when you are going to adjust your inflation pressure is very simple. You start with an initial breath and sort of get a handle on where things are. You have a target tidal volume. You measure the actual tidal volume, and then you increase or decrease your pressure in the direction needed to go in order to bring the tidal volume in line with the target. So that's a fairly simple concept. That's a similar algorithm for PRVC, pressure-regulated volume control, on the servo ventilators as on the volume guarantee ventilator on the Jaegere devices. The difference is that PRVC uses the tidal volume back at the machine and therefore uses numbers that are not reflecting what the baby's actually receiving. The other devices that, as I indicated, regulate the inflation time. So the way they work is you have a volume limit setting, and they basically are volume controlled ventilators. So here on the upper panel is your pressure waveform, the middle panel flow, and of course volume on the bottom panel. You're all familiar with these kinds of curves. And as long as the volume does not reach the limit, everything is running as normal. But if for whatever reason, and there seems to be some migration in my lines here, but if the tidal volume now hits the volume limit, inflation will be interrupted at that point, and that can result in very short inspiratory time and rather awkward type of respiratory pattern that the baby may not be all that crazy about. Here's an example of it from a screenshot from an AVIA ventilator. You can see inflation started, and then flow is still going in near peak velocity when exhalation begins, and there's very short inspiratory time, very little interpulmonary dwell time, very little time for interpulmonary gas distribution. So that's not a happy pattern for the baby. So we have talked a bit about volume guarantee as becoming increasingly the sort of prototypic modality that is become somewhat generic. People are starting to refer to volume-targeted ventilation as volume guarantee, even though strictly speaking, volume guarantee refers to it as implemented on the Jaegere device. But for example, AVIA has now implemented a version of volume guarantee on their device. How does this work? Here it's fairly straightforward. You pick the tidal volume, and how you do that is the most important bit. And we'll talk about what the right tidal volumes are. And you set a pressure limit. You give the machine room to maneuver, and it can then adjust the working pressure, the actual inflation pressure, up or down. It can go all the way down to PEEP. Then it can go up to whatever pressure limit you set. And it uses the exhaled tidal volume of the previous inflation. And it does that because, as you, I'm sure, appreciate, leak around in the tracheal tubes is more during inspiration. You can hear it. You can hear the whoosh during the inspiratory phase. And therefore, the exhaled tidal volume more closely reflects the actual inspiratory time. So that's all good, and that's in essence how it works. For those who may not be totally familiar with it, let me explain it. This is very interesting. The slide, somehow the lines migrated here. They used to be nice and jointed. Something happened in translation, so use your imagination and line them up here. Anyway, so up in the upper panel, you can see in green the pressure limit. You can see the pressure waveform. And in the lower panel, you see tidal volumes. And so with the first cycle, whatever the pressure limit, whatever the actual pressure, working pressure is, resulted in tidal volume that was on target. All's good. So there's no change in the pressure for the next inflation. But now the tidal volume falls a bit short of our target, and therefore for the next inflation we will have a step up in the inflation pressure. If in fact that results in the tidal volume within a couple of % of target, no change will occur on the next cycle. But if now the tidal volume exceeds the target, the pressure will be reduced for the next cycle. Now there's a secondary safety control, and that is if the tidal volume during the inflation hits 130%, so overshoots by 30%, the breath will be terminated at that point, and exhalation will begin. This is also compensated for leak to some degree. I'll talk about leak compensation in a moment. There is a real-time, within cycle monitoring of tidal volume as well, and if it exceeds by a large amount, it will terminate the cycle. So there's, in a way, a dual control, but that's a secondary one. The primary control is on the exhaled tidal volume. So you can see that if there are large changes, it may take a little bit of time for the tidal volume to stabilize again. So here we have a comparison between this novel mode of support known as NAVA, or neurally adjusted ventilatory assist, and volume guarantee. And the reason I'm showing this is they do in fact take contrasting approaches. So on the left-hand side, in the upper left-hand corner, is what's labeled as electrical activity of the diaphragm that reflects, in fact, the baby's respiratory effort. And so you can see on the left-hand side there is very little effort, and therefore the pressure generated by the ventilator is high. The ventilator compensates for lack of effort to try to keep the tidal volume stable. As the baby breathes more and the tidal volume exceeds the target, the pressure will drop to avoid exceeding the target tidal volume. So that makes a lot of sense for premature babies who have very irregular respiratory pattern, as seen on the right. In the right half of the slide, you can see the erratic breathing pattern of a very premature baby. On the top panel is indicated by this pneumatic surface capsule and rib bands and oxygen saturation. So this is an example of extreme periodic breathing with short pauses, short respiratory pauses. Well, so NAVA, neurally adjusted ventilatory assist, assumes mature respiratory control because it's a positive feedback as opposed to negative feedback of volume guarantee. NAVA is a positive feedback, so when the baby makes very little effort, it generates very low pressure, and the more vigorously the baby breathes, the greater the pressure the machine will generate. It was explained to me that it's kind of like power steering. The driver knows what to do. We just facilitate what the patient's trying to do. And that's great. But in the case of a premature neonate, I would argue that the driver is blind and drunk. They don't know what they're doing. They're very erratic and unsustained respiratory effort. And so NAVA potentially will amplify this periodic breathing, and it may not be the best way in preterm neonates. I like it as a triggering system because it avoids all the problems with pneumatic triggers, all the delays and all the effects of leakage. But I'm concerned about potential adverse consequences of this positive feedback mechanism. And on the next slide is an example of just how NAVA responds. On the top panel, again, is an electrical activity of the diaphragm, and you can see that it is highly variable in this baby. And the pressure that the ventilator generates closely parallels that. And you can see that this will result in highly variable tidal volume, which may or may not be the best thing for the baby. So I'll let you think about that. And we'll move on to what we know about the volume guarantee approach, because that's been studied much more thoroughly than any other modes of respiratory support. There's a handful of papers with other modalities, but not nearly as many, and none of them have really looked at an important major outcome. So we do have data, and I will share a little bit of it with you in terms of the benefits of volume guarantee. Include maintenance of a relatively constant tidal volume, and it's not completely constant because the baby is always perturbing the equilibrium with their irregular respiratory effort. Excuse me, but that's actually a good thing, because completely monotonous tidal volumes result in atelectasis over time. So some variability, physiologic variability, is important. We know that volume guarantee will prevent overdistension and volutrauma when lung compliance changes rapidly, as it does in all these interventions listed there. And very cool thing is that it results in automatic lowering of the pressure generated by the ventilator as the baby's lungs improve and as the baby begins to breathe more actively. It's real-time weaning. Volume guarantee doesn't wait for the next blood gas. It doesn't wait for rounds to make a decision. It's not afraid that the attending will yell at it for doing the wrong thing. It does what it's programmed to do in response to improving pulmonary status and baby's overall well-being and increased effort. So it does, among other things, leads to faster weaning from mechanical ventilation, something that most people agree is a good thing, getting the baby off mechanical ventilation as quickly as possible. And it will, again, compensate for that highly variable respiratory drive that I showed you on the previous slides by stabilizing the tidal volume and therefore minute ventilation, and avoid large fluctuations in CO2 that can occur with this extreme periodic breathing. So in fact, there have been now 2 large meta-analyses of a bunch of studies that have been published with various forms of volume-targeted ventilation. Most of the outcomes clearly favor volume-targeted ventilation. So this is not just volume guarantee. This included studies using other modalities of volume-targeted ventilation, to be clear. But there's a total of 11 studies included in this latest meta-analysis, upward of 750 infants. And while mortality was not significantly reduced, and for those of you who are not familiar with all the statistical mumbo-jumbo, the relative risk means just that. So if the relative risk of 1 is the baseline, and if it's less than 1, it's decreased risk. If it's more than 1, the risk is increased. And the numbers in parentheses indicate the confidence limits, confidence intervals, and if they do not cross 1, that means a significant difference. So in mortality, you can see that the upper limit is just above 1, so it's not a significantly statistically significant result, but the point estimate, which is this number here, the relative risk, suggests perhaps as much as 25% improvement in survival, reduced mortality. But all the other outcomes that they looked at, or that I listed here, are statistically significant. The number do not cross 1. And so there is a 35% reduction in the risk of any intraventricular hemorrhage, a 45% reduction of severe intraventricular hemorrhage, an almost 40% reduction in chronic lung disease, a 2/3 reduction in the incidence of cystic periventricular leukomalacia, and more than 50% reduction in the incidence of pneumothorax, reduction in the incidence of low CO2s, although only 2 studies looked at that. One of them was our small study, and there was a shorter duration of supplemental oxygen again. So not all the studies looked at all of the outcomes, but here are the data. So there is pretty strong evidence. Meta-analysis is considered what's called level 1, or the strongest type of evidence in favor of an intervention. So why aren't we doing it? Well, good question. Acceptance has varied across countries. It's very much more used in Australia, in Scandinavian countries, and other parts of Europe, not so much in North America. And I'm speculating as to why exactly. Some of it is just inertia, which is probably the most powerful force in the universe. Now, we have always done it that way, and maybe that we're comfortable with that. I don't know about this other thing. And if you're comfortable and don't want to change, you can always rationalize and say, well, we need some more evidence. I'm not convinced that this is really better. Well, we now have 2 meta-analyses, so that argument's starting to really not hold water very well. And then perhaps there is some lack of understanding. This is a paradigm shift. It does require significant shift in how one approaches these babies, and we'll talk a little bit about how to implement this in a moment. So there are some issues, and there's some technological limitations, and some issues in how to apply it. But these are all not so difficult to overcome. We just have to be willing to abandon our comfort zone and not keep doing it the same way just because we always have. So I wear this button on rounds to annoy everybody and try to get them to consider that maybe there are other ways. But before we move to specifically how to implement volume-targeted ventilation, let me quickly talk about some of the benefits or some of the importance of distributing that tidal volume evenly into an open lung. And just exactly what do I mean by that? Well, here is a cartoon and a couple of images. So in the lower right-hand corner, you have typical chest X-ray of a baby with bad RDS. And we think of it as homogeneous disease. But if you, in fact, take a cross-section with a CT scan or MRI, it turns out that most of this atelectasis is, in fact, posterior. It's gravity-dependent, and that you have aerated lung anteriorly, in a cartoon form shown in the middle panel. And what we have is all kinds of lung injury going on at the same time. The allectatic portion is getting injured. There's proteinaceous exudate filling the alveoli and inactivating surfactant. There are shear forces at the boundary between aerated and unaerated lung. But perhaps most importantly, there is going to be lots of volutrauma even if you are controlling the tidal volume to a normal physiologic value. And this is because we know from Laplace's law, you remember your basic physiology, the compliance of the alveoli that are already open is greater than those that are collapsed. The critical opening pressure of the collapsed alveoli is much higher than that of the aerated lung, and therefore the tidal volume will preferentially all go into the already aerated portion of the lung, and therefore there's a great deal of maldistribution of tidal volume. It'll all go into perhaps a third of the alveoli, and with a tidal volume of 5 ml per kilo, which would be kind of your normal target, you're actually using the equivalent of 15 ml per kilo into the open portion of the lung. And clearly that's going to injure the lung, and do so in a fairly short period of time. So we need to do something to get the lung happily aerated universally. I don't have the ability to make this little movie run, but if I did, you would see this nicely aerated lung collapsing back to what it looked like on the previous slide in a matter of about 3 seconds. So this is recruitable lung volume, and we recruit it by getting up above the critical opening pressure of the collapsed lung, and then maintaining that aeration by keeping the end expiratory pressure above the critical closing pressure. So this is our ultimate goal. The question is, how do we get there? So this is another cartoon sort of depicting the process. If we were to move across from the bottom. I'm still struggling to figure out how to make my pointer work, because I don't think it is working, and I'm not sure why. But anyways, if we so we start on the left hand of that row of pink dots with a fairly collapsed lung, and we have to go through some sort of recruitment maneuver. This same state is shown with that red oval on the inspiratory limb of the pressure-volume relationship, and you can see that the compliance is poor. That's a diagonal line. And what we have to do is go through a recruitment maneuver. There's different ways of doing it. With conventional ventilation, you generally do it just by cranking up your end expiratory pressure. With high frequency, do it by increasing your mean airway pressure. But there is probably transient overexpansion of the more compliant portion of the lung, and that apparently is okay. We get away with it for a brief period of time, because subsequent to that we back off. We slide down the expiratory limb of that pressure-volume relationship, and we try to find that happy spot on the expiratory limb and ventilate in that green zone of optimally aerated lung with a relatively low tidal volume, relatively low mean airway pressure, and good ventilation perfusion matching. And so here's just one slide from a study done in the Netherlands, where they looked at a series of babies in whom they performed these lung recruitment maneuvers. So there are two vertical axes. On the right is the FiO2, and on the left-hand vertical axis is the distending pressure and the CDP. And so you can see that early on, the FiO2 was high. That's the white bars. And this continuous descending pressure was relatively low. They stepwise increase the pressure until saturations improve, and they're able to wean FiO2 down to less than 30%. So the second column labeled open, the FiO2 is low, the descending pressure is fairly high, about 20 centimeters. And then they will stepwise reduce the pressure to try to find that sweet spot. So it's important to not leave the descending pressure at the maximum that was needed to open the allectatic lung. Remember that once you open the lungs, they become more compliant. And so once they're more compliant, they need less pressure to keep open, and that's what you're trying to find. So you slide back down the expiratory limb, and you can see where they just find the place where the saturations begin to deteriorate. That's a closed column where the descending pressure is down quite a bit. FiO2 is still okay. and then you go back up just a little bit and try to stay at that sweet spot. Now what they found was they were in about 25% oxygen with a distending pressure of less than 15 centimeters. And that's kind of the concept, the open lung concept, that we should all appreciate as a very important part of any lung protective strategy. So the healthy lungs are relatively easy to ventilate. They stay open, the alveoli stay open during both inflation and expiration. But the injured lung, of course, the problem is that at the end of exhalation, the unstable alveoli collapse. So one way to get around it, people have proposed, of course, is high-frequency ventilation, and it probably does that very well. Everybody knows that the way to use high-frequency ventilation is to use it with the open lung strategy, the optimal lung volume strategy, and that certainly maintains lung volume and probably has some lung protective effects. But it turns out that what probably is important is not how you get the lung open, but that you do get it open. So here are some animal studies that looked at acute lung injury score. This is a histologic score. They lavaged the lung to get rid of surfactant, and then they ventilated in the extreme right-hand column with just plain old bad positive pressure ventilation, large tidal volume, low end expiratory pressure, very injurious way of ventilating, and therefore had a very high lung injury score. In the second column from the right, labeled HFOV, with the open lung concept, you can see that indeed they achieved much lower lung injury scores, but next to it is our animals that were ventilated with conventional rates, but open lung strategy. And you can see there was just as much lung protection using that approach. So this suggests, and many other studies of a similar nature suggest, that it isn't really the high frequency itself, but rather the fact that we are routinely using the open lung strategy with it, and perhaps arguably in some babies, some of the sicker babies, it is easier to achieve lung volume recruitment with high frequency. But if we can achieve it with conventional ventilation, we probably have the same benefits. So it's the open lung strategy that's key. And perhaps some support for that might come from the study seen here, where two studies were done looking at volume targeting. In the first study, they used tidal volume of 5 ml per kilo and showed a reduction in pro-inflammatory cytokine levels and decreased duration of ventilation. And when they reduced the tidal volume even some more, but used lower end expiratory pressure, they actually had more lung injury. And this is probably because low pressure, low end expiratory pressure, and low pressure because of the low tidal volume resulted in a lot of atelectasis. So that doesn't work so well. So there are a bunch of studies that have looked at volume-targeted ventilation. Here's an old study that we did a number of years ago looking at volume guarantee, and we showed significant reduction in hypocapnia, but there were still some babies that CO2 was a little bit low. There are lots of reasons for that, including babies compensating for metabolic acidosis. And we showed that you had fewer excessively large tidal volumes, but babies are always perturbing the equilibrium, so the tidal volumes do fluctuate. Now, getting a little bit out of time, so I'm very quickly going to run through some of the practical applications, and hopefully we'll still have a few minutes for questions. So how should we do this? Well, because lung compliance changes most rapidly soon after birth, it's probably a good idea to start volume guarantee right off the bat. And depending on the kind of baby that you're ventilating, you pick the right tidal volume. In a typical preemie, in the first day of life, somewhere around 45 ml per kilo works, 4.5 on average. But different babies need different tidal volumes. One size does not fit all. So if the baby is really, really small, less than 600 or 700 grams, you probably need 5.5, maybe even 6 ml per kilo, and I'll show you why. Babies with different pathophysiology, like meconium aspiration or chronic lung disease, who have increased alveolar dead space, air trapping, overexpansion, also need larger tidal volumes to achieve the same CO2. Then you have to set your pressure limit so that the machine can adjust the working pressure both up and down. And we need to keep it, roughly in that relationship, because it's among other benefits of volume-targeted ventilation. If you had everything good, tidal volume is being reached with a pressure limit of 20 or 25, whatever you had it, all day, and all of a sudden it's alarming, and it's alarming persistently, something's changed. And you don't have to wait for a blood gas. This gives you an early warning that something isn't right, so you go and check on the baby, see what happened, whether the tube slipped into the right mainstem bronchus, whether there's some occlusion, there's some atelectasis, there's pneumothorax, who knows what. Maybe overdose, maybe the nurse gave a little too much morphine and the baby stopped breathing. Lots of possible reasons. We just need to sort it out. So here's an old study that's actually now been published. That we looked at a bunch of babies with meconium aspiration, thinking that, these babies have a lot of air trapping, overexpansion, they have increased alveolar dead space, they probably need a bigger tidal volume, and they did. Substantially bigger tidal volume compared to similar-sized infants with more homogeneous disease. They were also more tachypnic, so their minute ventilation, their total minute ventilation was quite a bit higher. But the CO2 is identical, which suggests that their alveolar minute ventilation would be the same, and this is all wasted ventilation due to the nature of the disease. So different diseases need different tidal volumes. When volume guarantee, quote unquote, doesn't work, it's almost always because we picked the wrong tidal volume. So here's some data to indicate why very, very, very small babies need bigger tidal volumes. We looked at a bunch of babies less than 800 grams and looked at, whenever we had a blood gas, we looked at what the tidal volume was. And when the blood gases were within a normal range, this is what we got. The bigger babies, the 800 grammers, the tidal volume was about 4.5, 5 ml per kilo, just as we had previously determined. But when we looked at the other end of the spectrum, the ridiculously low birth weight infant, around 400 or 500 grams, so it was closer to 6 ml per kilo, and this has to do with the dead space of the flow sensor. So when the flow sensor is whatever it is, 0.8 ml, the baby's a kilo, all right, it has a significant impact. When the baby is half the size, the flow sensor dead space is still the same, so it has a bigger impact, and that's why you need a little bit of compensation for in those really tiny babies. So it seems a bit counterintuitive. People try to leave these little babies and smaller per kilo, but that would be the wrong thing to do. And now you see why. We also recognize that we were ventilating these babies with tidal volumes that were no larger than their tidal volume, than the dead space volume that we estimated and measured. And it turns out that we, in fact, do ventilate babies with tidal volumes that are no larger than dead space. So here we have the standard respiratory physiology that you're all familiar with. In the left-hand panel, we have the standard little boxes moving in. So in red is the dead space. At the end of exhalation, exhaled gas rich in CO2 sits there. When you breathe in 5 ml tidal volume, only 2 ml of fresh gas moves in, supposedly. If you reduce tidal volume from 5 to 4, you still have 3 ml dead space. You would only get 1 ml of fresh gas in, and when you reduce tidal volume to 3 to equal dead space, you would have no fresh gas entering the lungs. But that actually doesn't happen, and I guess I don't really have time to go through this, but I will point out that we proved on the bench that this conventional physiology isn't exactly right, and that we were actually able to wash out CO2 out of the lung with tidal volumes even below the measured dead space, and that the concept of dead space isn't totally fictitious, but it isn't totally real either, because there aren't little boxes that move in and out, and there's in fact some streaming of fresh gas through, that penetrates through the dead space, somewhat like in high-frequency ventilation. So that's just to give you a little tidbit, but time doesn't quite permit for that. I will just point out that older babies, as they develop chronic lung disease, also progressively need larger tidal volume. These are the same babies we started with, less than 800 grams. And as they remain on ventilation, they progressively need a slightly larger tidal volume, even as we allowed CO2 to rise from the mid-40s to the mid-50s. So these are all little caveats that you have to understand in order to apply volume-targeted ventilation optimally. And the last thing I will say is that with the new VN500, we now have a ventilator that has very effective leak compensation. With the older models and with some of the other volume-targeted ventilators, you have a big problem when you have a significant leak around the endotracheal tube, and the leak tends to get bigger as the baby gets older. The VN500 has an extremely effective leak compensation mechanism so that you can ventilate accurately with tidal volume measurements, still being accurate by correction based on this algorithm. that allows us to use accurate volume measurement and volume targeted ventilation with leaks upwards of 70 or 80%, which is pretty remarkable. And so there's really virtually no circumstance where you cannot use volume guarantee. So the bottom line in terms of strategies for prevention of lung injury, we talked about most but not all of them. Optimal delivery room stabilization is certainly important. Avoidance of mechanical ventilation seems to be more important perhaps than other things next to this. But once we do have to ventilate, avoiding excessively large tidal volume is critical, both in terms of lung injury and brain injury. Optimizing lung volume is critical in making the other strategies work. So allostatic lungs are bad. If you ventilate them, we're going to get into trouble. And you know there's atelectasis if you have a high oxygen requirement, pretty much in a premium with RDS. There are other strategies, obviously. Surfactant helps, but volume-targeted ventilation coupled with optimal lung volume strategies probably are the most important of the things we can do. And so thank you very much for your attention. In case you're wondering, that's me raising funds for the next research project. And so thanks for your attention, and I'll be happy to try to tackle any questions.
Thank you, Dr. Kessler. That was great. As you were speaking about the babies and volume-targeted ventilation, I was transported a little bit back in time to standing at the baby's bedside next to the old Sechrist ventilators delivering surfactants, and then standing at the Sechrist ventilator for, quite some time, monitoring pressures and adjusting as the baby's compliance changed in the context of volume guarantee, volume targeted ventilation. When we deliver artificial surfactant, is that something that we'll need to hang out at the bedside and adjust?
Yeah, that's a great question, and one of the dangers of these faster-acting surfactants indeed was that compliance would improve rapidly, and if people weren't as diligent as you were and went to get a cup of coffee instead, you could come back and have a CO2 in the low 20s. So yes, volume guarantee would take care of this issue. Of course, with very small babies, when you dump surfactant down, there is a transient obstruction of the small airways, or even of the larger airways in the endotracheal tube itself. So there can be some challenges, and you have to transiently, the machine will initially compensate and will bring up the working pressure to push the material through, and once it does succeed in doing that, and compliance begins to rapidly improve, the working pressure would come down. There's one caveat that it's important to know. If the ventilator, and specifically talking about the Jaegere, I'm not sure if all of the other devices respond the same way, but the Jaegere ventilator is a safety feature. If it detects complete obstruction, there's no tidal volume at all, it will drop the inflation pressure, because it assumes that there is a kink in this system somewhere, and if it kept going up on the pressure and then suddenly it's unkinked, it would hit with excessively large tidal volume. So you have to be aware that if the ventilator senses complete obstruction in volume guarantee mode, it will drop the peak inflation pressure by about half. So you need to monitor it. If that happens, you would have to apply some manual inflations to get it through. Once there is, again, some measurable tidal volume, it reverts to a normal operating mode. But that's just a little caveat that's important to know. But your question is excellent. It is this is what volume guarantee does. It responds to changes in delivered lung volume, tidal volume, and adjusts to obviate you having to stand there for a half hour responding to changes, because it will do that for you in real time.
Thank you very much. The other issue that we've respiratory therapists have been dealing with for decades in our nurseries is the basic 4 different sizes of endotracheal tubes that we have that are uncuffed, and the 4 sizes have to fit everything from our ridiculously low birth weight babies up to our post-term kiddos who are relatively large. With volume guaranteed ventilation, volume targeted ventilation, how detrimental is that endotracheal tube leak to achieving the goals of that mechanical ventilation mode?
Yeah, this is an important issue because in the old days when we all used pressure-limited ventilation, and indeed one of the reasons why pressure-limited ventilation became so popular is it doesn't care about the leak. You can have a 50% leak and you're still ventilating just fine because you weren't measuring tidal volume and you were just looking at chest rise and breath sounds and checking blood gas as well. So what to do? So we have fortunately some technological advances that mostly take care of it, but if you don't happen to have that ventilator, it remains an issue. So the standard, the volume guarantee on the Babylog 8000 Plus was okay up until about 35, maybe 40% leak, and beyond that, the tidal volume measurement now begins to significantly underestimate, and you can inadvertently overventilate because the machine thinks you're only delivering 3 ml, and in fact you're delivering 4 or 5 or who knows what. And so some people who like to use to believe that there should be a leak, and there are many practitioners who think that to be safe, to avoid the risk of subglottic stenosis, there should always be a leak. There's no basis for that belief, but it's a widespread belief. So in those situations, people often set a tidal volume that's fictitiously low. What's being delivered is more, but they kind of compensate manually for the leak. The 8000 could do fine with leaks up to 35% or so. The VN500 has that compensation algorithm that is amazingly effective, and so it becomes much less of a problem. I would still change the tube for a larger size if the leak is more than 50%, just because as you wean, then the baby's having to breathe through less of a straw. And that's, of course, one of the problems in small babies when we're trying to wean them, and please don't use SIMV alone as a weaning practice in small babies, because it's very hard for them to breathe spontaneously through these long, narrow endotracheal tubes, and they end up fatiguing. So in any case, a very large leak is probably something that you should correct, even if you have the ventilator that will compensate for it adequately. In the old days with the older ventilator, you had two choices. Basically, if the leak was 50%, you could either recognize that you just can't do volume-targeted ventilation accurately and just go back to the old days of pressure-limited ventilation, or you could just simply reintubate the baby. What happens is the trachea and larynx stretch over time. If a baby's ventilated for a couple of weeks, there's always going to be a large leak. If you think about it, if you do the math very quickly, when you ventilate at a rate of 60, that's 76,000 inflations per day for 24 hours. And these are immature cartilaginous structures, and they stretch. So people sometimes get skitsy when I want to change an endotracheal tube to a 3-millimeter tube in a 750-gram baby. You can't do that. And I said, look, there's a 50% leak. I can drive a truck through there. So the initial, size guidance is at birth, and the larynx does stretch. So if you have a huge leak, you just put a bigger tube in. That solves the problem.
Wonderful. Thank you so much, Dr. Kessler, for joining us today.
You're very welcome. I hope people learned something useful. I certainly enjoyed it, and I look forward to working with you in the future, perhaps on other occasions. Thank you very much.
Thank you. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation.